millions with chronic infections and claiming countless lives. The World Health Organization launched an ambitious viral hepatitis elimination agenda aimed at achieving a hepatitis-free world by 2030. Crucial to the success of this mission is the role of case detection, testing, and diagnosis. During this session, we will hear about updates from WHO guidelines and share insights on the journey towards viral hepatitis elimination. And we will also showcase most recent results on hepatitis C self-testing research from the STAR Consortium and discuss how these findings could potentially inform hepatitis B antigen self-testing and the use of multiplex test kits in the context of triple elimination. I will briefly, I will not introduce myself. We've got our bios here for our chairs on the screen. I'm Christina Grabian. This is my co-chair, Heather Ingold. And I will now pass to Heather to introduce our first speaker. Thank you.
Thank you, Christina. Good morning, good afternoon, everyone. Our first speaker is Dr. Nicholas Lumen, Technical Officer, Viral Hepatitis Prevention, Testing, and Priority Populations at WHO headquarters in Geneva. Nicholas will be presenting on the WHO's viral hepatitis agenda and the central role of case detection and diagnosis. Nicholas will be coming to us live from Geneva. Nicholas, over to you.
Hi, thank you, Heather. Thank you, Chairs. Just to check, can you see me and hear me?
We can hear you fine, and now we see you.
Okay, so maybe IT can share my presentation. Hello to everyone. It's lovely to join you. Thanks for the organizers to having us at this important session. I hope you have a wonderful week and interesting week in Harare. As Heather has said, I work at WHO Geneva and will share a couple of slides as a form of introduction on our elimination agenda and the role of case detection. Next slide, please. So this slide shows you basically in the middle that we have a global health sector strategy for respectively HIV, viral hepatitis, and STIs. And I think the two main messages from that strategy that I will bring us to 2030 that I want to share is that, first of all, it focuses really on person-centered and integrated care across those three disease areas, and thus show the opportunities of more integration of those three disease areas. The other thing that it shows, among many other things, is a clear targets for that will bring us to elimination. And on the right, these are not all the targets, but it's it shows you the impact targets for incidence and mortality. But unfortunately, a red box is a bit shows a little bit skewed. But basically, under coverage below there, it shows you that we have quite ambitious targets for testing, diagnosis, and treatment. And this is a core intervention area for hepatitis B and hepatitis C. And we hope that 90% of people who live with chronic hepatitis B and C know their status and know that they live with the disease by 2030. And obviously for that, we need to step up case detection. We do have as well a validation guidance that shows on the left that has similar targets, very close to those elimination targets. And basically this guidance is new from this year. And it really, like for other disease areas, allows us to certify countries that they have achieved viral hepatitis as a public health problem. Next slide. And the first country that has made use of this guidance is Egypt. You might have heard about this story. They have been certified only several weeks ago to have achieved gold tier. And we're showing this because we think this is a really great success story. Gold tier means that you have made huge progress in program coverage and not yet completely achieved full elimination, but this is the closest tier to full elimination. The other two things, besides the photos that show some pictures from the celebration, is on the left, you can see how they organized their screening. And this was really a lot in primary healthcare units and then additional in hospital and mobile units, for example. So a very health systems and decentralized screening strategy. the graph on the lower part, just look at the red. It shows you that within 2015 to 2022, they've reduced the chronic prevalence of hepatitis C because it became a curable disease from 7 to below 0.4%. So this is a huge achievement that is based in screening and treatment. Next slide. This is another slide that shows the importance of screening and case finding. It's a kind of, you could call it a double cascade. So in the middle is case finding, and then depending if you find that someone has a positive reactive test to hepatitis B or C, you can refer to care, further diagnosis and treatment to the right red, or you can, if it's negative, refer to prevention services, including hepatitis B vaccination and other prevention services. I think as well, case finding, just to mention, can really drive understanding the epidemiology in a country better, and as well support patient advocacy. So it's really central to the cascade and other aspects of the response. Next slide. So all that withstanding, the testing gap is huge. And just to say, on the left, you see the numbers for hepatitis B, and on the right for hepatitis C. Only 10% globally know that they live with chronic hepatitis B, and above a little bit more than 20% know that they live with chronic hepatitis C on the right graph. You can see for the region where you're in, which is largely the WHO African region, that those rates are even significantly lower. So really a huge testing and screening and case detection gap. Next slide. So what are we recommending? Just very quickly to show, it is very important that a country thinks through what are the main populations and settings where case detection can be built up and integrated, and as well use those opportunities. So we're recommending basically in terms of who to test, that in all epidemic scenarios for hepatitis B and C, those who are most at risk and most affected by hepatitis B or C are important populations to offer screening. Then there is those can include HIV-infected people, people from key populations, and, for example, migrant populations and many others. Another very important group is really those with a suspicion of liver disease or viral hepatitis showing symptoms or laboratory markers. Those are very important and good to think through where they can be found and identified, because they might have actually advanced liver or beginning liver disease, and very important to offer treatment. Specifically for hepatitis B, which is very prevalent in the African region and has a very high burden, we recommend as well to test sexual partners, family members, and children, and other close household contacts of people with hepatitis B infection, and the health workforce. Next slide. Then, no, the other one. Just one before. Yes, thanks. Then as well, if you look at the bottom first, we do recommend, and there was a reference in the introduction to that, we do recommend as well to test all pregnant women for hepatitis B in the framework of triple elimination at least once in their pregnancy as early as possible. So this is a very important aspect, and this area gains a lot of traction in countries, and is really something very interesting. Then overall, we recommend two other possibilities just to frame testing and screening strategies. Is that in those countries where you have a more generalized epidemic above 2%, or for intermediate or high prevalence for above 5%, to consider testing and screening strategies for all adolescents and adults within routine healthcare systems. And then there can be as well interesting age-based screening strategies, because often, even for hepatitis B, it's more documented for hepatitis C, but often for hepatitis B and C, prevalence is higher and yield could be higher in those population groups. Next slide. This is just to very shortly say that specifically for hepatitis C, we have a rather recent self-testing recommendation as an additional approach to testing. So you would know that you start with a serological test. We recommend that you can use an RDT or a laboratory test. And now we recommend as an additional approach the possibility to use RDTs as a self-test, as we do for HIV. And we're considering as well to develop that for hepatitis B. In the case of hepatitis C, this has to be confirmed then with a molecular or a core antigen test in a second step. Next slide. So this was just, I wanted to show you, it's not about the accuracy of the table, but if you look on the left, I just wanted to highlight some of the huge opportunities that come with thinking through integrated testing approaches. We talked a little bit about the key population groups and key groups that we can focus on, and here are some of the key settings. So there's the formal healthcare settings, where you can look at integrating hepatitis testing in your HIV clinics, TB, STI clinics, pediatric clinics, drug treatment centers, and even primary healthcare settings, for example, if you want a more generalized or age-based screening strategy. And then obviously there's the opportunities in community-based testing that we know from other disease areas. It could be house-to-house or mobile outreach or really campaign-based. And I think the picture shows one of those opportunities. So there are a lot of opportunities that are not always used enough, and important to think them through. Next slide. So what are the barriers? And really there's quite a lot. And I think some of them for people who work mainly on HIV might seem a little bit long ago or funny, in the sense that really hepatitis is at that different level of its response. And one of the key areas we see more and more coming out and know now about more and more is that really awareness across policymakers, patient and healthcare workers is low, and that it's not really recognized the importance of a strong public health response for viral hepatitis C and B. It's growing, but there's a lot of work to do in this area. Then there's stigma and discrimination, and that is quite different between hepatitis B and hepatitis C, but exists for both of those. There's a lack of testing, infrastructure, and capacity as well in many countries. In terms of the products, there is quite some rapid diagnostics tests for hepatitis C now pre-qualified and of good quality, much less, unfortunately, for hepatitis B, and we hope that there's more coming, but there's only 2 pre-qualified tests. Similarly, for molecular tests, we have more centralized and point-of-care options pre-qualified, and we know of more quality-approved choices in hepatitis C than in hepatitis B, where point-of-care testing will become more and more important as well as we scale up the public health response. A little bit, the elephant in the room is really financial support to the hepatitis response. And I think there is no clear pathway. There is some of the stakeholders, such as the Global Fund and many others, that have shown more openness to integrate hepatitis B and C services. But countries are sometimes really struggling with financing a strong response and a scaled up response. Next slide. And that obviously relates to case finding as well. In summary, I just wanted to show that case finding and diagnosis is central to elimination. You've seen the targets. We have a validation guidance, and really it's at the center of a double cascade, somewhat referring to prevention and then can link as well to care and treatment. Countries need to make progress, and we think it's a very important area to think through strategic approaches that are cost effective, that are embedded in your healthcare systems and based in epidemiology, so that an initial progress can be driven by case detection and finding. And we're looking at innovations such as self-testing and multiplex, and we may hear a little bit more about it, sorry. And then integration and decentralization is really one key piece to drive the response as well. I hope I showed it quite clearly, and I'm staying on for the discussion. Thanks a lot for having me, and it's very important that we have a satellite session on this important area of public health. Thanks a lot and have a great week.
Thank you very much, Nicholas. It was an excellent presentation, and thank you for staying on the line for when we get to questions. I'd like to introduce our next presenter, Vanessa Solomba from Essentia in South Africa. She will be presenting on the outcomes from the STAR hepatitis C self-testing research in Cameroon, Nigeria, and South Africa, with emphasis on the results from South Africa. Over to you, Vanessa.
Good afternoon, everyone. I'll be presenting on the self-testing for hepatitis C among priority population groups in Africa and focusing mostly on South Africa. Next slide, please. Just some important points to raise about hepatitis C self-testing. It is not to replace any testing modalities that currently populations are able to know their status. They are currently not, it's not a definitive test, so every positive that is found on hepatitis C self-test needs to be confirmed using the national algorithm. And they're currently research only, so these self-tests are not available on the market. Next slide, please. The Unitaid STAR hepatitis C self-testing project countries are Nigeria, Cameroon, South Africa, India, and Vietnam. And these countries were selected because of their disease burden, as well as their potential strategic and potential influencing role for the hepatitis C self-testing market. These countries also have prior experience with HIV self-testing and their potential integration of hepatitis C self-test and HIV self-test at program level. Next slide, please. Just to tackle some of the use cases that the countries are currently focusing on, all countries are doing facility-based direct observation. This is basically directed at the general population. And in Cameroon, they're focusing on those that are over the age of 45 that are coming through the chronic disease health facilities. All countries are also carrying out community-based direct distribution, including outreach programs. And these are currently being done by CBOs that are working at harm reduction programs and focusing and directing at people who inject drugs. Innovative modalities like virtual platform as well as online distribution were very successful in HIV self-testing, and these are being done in India and Vietnam. Another use case is the secondary distribution to sexual and injecting partners of people who use drugs and MSMs, men who have sex with men. So when an index case is found, they're offered a self-test, and these are basically, we're trying to reach people that would not normally come to a health facility. Next slide, please. Okay, so now just to get into some preliminary results in South Africa. Our setting is in the Yeoville harm reduction site as well as the outreach sites in Johannesburg. Our primary objective is to measure the effectiveness of hepatitis C self-testing in hepatitis C testing, as well as linkage to confirmatory testing, diagnosis, treatment among key populations in Johannesburg. Our secondary objectives are to evaluate the effectiveness of efficiency as well as successful, basically how the participant interacts with the device, and to assess participants' adherence to hepatitis C treatment and completion of that regimen. It's a prospective observational study to assess the effectiveness of hepatitis C testing in diagnosing hepatitis C among key populations. I've already mentioned the use cases we are focusing on, and the population targeting are people who inject drugs, people who use drugs, sex workers, as well as men who have sex with men. Our sample size is 1,650, and this is an equal split between those that are going to be using the oral fluid test as well as the blood-based test. Next slide, please. So currently we have enrolled 1,279 participants, of which 90.6% have been people who inject drugs. 7.5% have been people who use drugs, and of those that, the 90% of those that actually inject drugs, 62.5% stated that they have actually shared a needle or syringe with someone. And 97.4% of the participants enrolled actually reported that they have never been tested for hepatitis C before. Next slide, please. All the participants that are enrolled in our study have been 18 years and above. We are seeing a mean age of 32, and majority of those are people who inject drugs, and they're male. This is because we do not see as many females that inject drugs. And about 87% have been participants that actually have primary school to high school level of education. Next slide, please. So just to talk on the feasibility of the self-test, we have seen about 92% of the participants rated the self-test very easy to use, and 93.2% rated the self-test process very convenient, and about 84.9% said they were comfortable with the self-test process. We have also seen a concordance rate of 98.9% between the self-test read by the participant versus the self-test read by the trained observer. Next slide, please. Just to take you through the cascade, of the 1,279 participants we've seen, 960 have been positive as read by the trained user. 955 have been interpreted positive by the participant. That discrepancy is just due to the participant interpreting the test wrong. One called it an invalid and one called it a negative when in fact it was a positive. 946 participants actually consented to confirmatory testing, but 933 agreed to actually have a blood draw done. And we were only able to do a blood draw on 931. And this was usually due to collapsed veins or some actually opting out of the blood draw, because believe it or not, actually, we have seen that even though they inject drugs, they're actually scared of needles. And we had one lost to follow up. They promised to come back for a blood draw and they never did. Of the samples that have been sent to the laboratory, 824 have come back HCV RNA detected, and 62 have come back RNA undetected. We have currently only initiated 1.6% on DAAs. These are direct acting antivirals, and this is because we only started initiation about 3 weeks ago. This was due to a delay in the procurement process, and we had to actually procure drugs from India, and then they had to be manufactured, so there was a delay. So in that case, then none have completed treatment as yet. Next slide, please. When we asked participants in the future, would they prefer to be, how they would prefer to test for hepatitis C, a little over 60% said they would like to test themselves at home. Next slide. And when we asked them in the future, would you test at home if you were provided the hepatitis C self-test with the instructions for use? And about 90% said yes, they would. Next slide, please. And when we asked them to which extent they could trust the self-test result, over 80% said they trusted the self-test result. Next slide, please. So just some lessons learned for the study. We've learned that integrating hepatitis C self-testing with existing health services enhances accessibility as well as convenience. Mobile and outreach services are effective in reaching populations with hepatitis C self-test who would not normally have access to health facilities. Acceptability was high, accuracy was high, and most of these participants were actually able to administer the self-test on themselves. Offering choice of the different tests actually increases acceptability and uptake. Timely engagement with relevant stakeholders actually also has encouraged buy-in. Community advisory boards with key actors in the viral hepatitis C space enhances national acceptability and accountability, of which we have done currently. We have actually engaged the NDOH already. And implementing linkage to care is essential to ensure individuals who test positive on the self-test are actually linked to appropriate health services. And this study has also contributed to awareness creation and advocacy for increasing hepatitis C testing coverage, given the high number of participants that we actually found that are actually positive, and especially the high percentage of people that have never tested before. Next slide. So just Thank you to our consortium leads as well as our partners. Thank you.
Thank you so much, Vanessa. Great presentation. We'll ask you to hold your questions for our presenters. We've got the next phase of our session is a great panel discussion. So I have the pleasure of directing a couple of questions to my close JPIGO colleague and our colleague from NASCAP in Nigeria. My first question is to Dr. Victor Adepoju, who is the lead for the STAR hepatitis C self-testing work in Nigeria. Victor, you're leading the work on in Nigeria on on hepatitis C self-testing. Can you speak briefly about the major outputs from this work and how the research will translate into policy shifts to increase hepatitis C testing, diagnosis, and treatment uptake in Nigeria?
Okay, thank you very much, Christina. So for us in Nigeria, our study recruits 2,000 patients. 1,000 were given 1,000 oral fluid and 1,000 blood-based. We distributed these kits in key population one-stop shop for people who inject drugs, men who have sex with men and females, and sex workers, while the ART clinic. So for the OSS, you can either be HIV positive or negative, and for the ART clinic, of course, just for PLHIV. In terms of our finding, I think it's not too different from South Africa, but a little bit different. So we give them choice between oral and blood-based kits, and 65% of them went for blood-based, while oral, 35% of them went for the oral quick. And that's one of the lessons we learned, the power of choice. And people prefer different kits based on different reasons. Those who went for blood say they believe it's more accurate, and the rest of them. Interestingly also, in terms of most of them, more than 95% of them also found it very easy to use. The instruction was easy to follow, and they were able to interpret the self-test result very easily. 43% of them went for unobserved, because we also give them the choice to either do it under observation in the presence of a trained healthcare worker, or take it to their houses, or whatever place is convenient for them to do it themselves. 43% of them actually went for unobserved, while the remaining 57% did it in the presence of observation of healthcare worker. But interestingly, when we asked them how they would like to use it in the future, the number that wanted to use it as unobserved increased to 62%. 62% of them said they will use it in unobserved setting in the future, while another 72% said they would like to use the commodity at home if given the option, choice in the future to do hepatitis C self-test. And that also, one of the things that we learned, that patients sometimes also need that confidence. They need to build that confidence at the initial time of testing, and for them to be able to really be able to do it themselves in the future. These are some of the things that we have learned. Another fantastic result that we are very excited about is our linkage rate. Out of about 219 that were HCV reactive, we link 216 of them, almost 99% to confirmatory RNA PCR. Our viremic rate is 80%. 8 out of every 10 people that were HCV-ST reactive came out viremic when they went for confirmatory testing. And about 98% of them were actually linked to confirmatory testing. The reason why this is so is because in Nigeria, Nasarawa State, where the study is being held, we have GeneSpar machines that have been optimized to do viral load, in addition to TB sputum tests that they were doing. And this is like every district has an average of 1 GeneSpar machine. So it was actually easy, especially for the ART site. They have an embedded GeneSpar machine, and for the one-stop shop, we're able to create an hub-and-spoke system that enable samples to be moved on behalf of the patient to the GeneSpar site. So 98% went for confirmatory tests, and 80% of them were viremic. 95% have started treatment, and we have data on the first 2 months cohorts that have completed 3 months treatment. The first cohort of June, 92% of them have completed treatment, while for the August cohort, as at last week, it's about 80% of them that have completed treatment. Thank you very much.
Excellent. Thank you so much, Victor, for sharing those lessons. A lot of great work being done. And this work, of course, being done in partnership with and under the leadership of the National AIDS and STI Control Program. And Dr. Jamiu Ganiu, we're pleased to have you with us also here today from NASCAP in Nigeria. Dr. Ganiyu, what are the key challenges and obstacles that you face in Nigeria in your efforts to eliminate viral hepatitis, and how can stakeholders, including the public, contribute to overcoming these challenges?
Okay, thank you very much for your question. I want to say that despite making significant progress regarding national response to viral hepatitis in Nigeria, we are still saddled with some challenges, and this include low awareness of viral hepatitis is still a major challenge. And also, among the health workers who are supposed to provide treatment, we are still having knowledge gaps, especially among those that actually provide service at primary and secondary care facility. Also, another key challenge is the fact that it is still treatment for viral hepatitis is still borne out of pockets. 70% of Nigerians still pay out of pocket to access viral hepatitis, and this is has limited access to actually accessing services. And also, stigma and discrimination is another challenge which I think it needs to be addressed. And also, we have the issue of suboptimal reporting. We are doing a lot, but unfortunately, due to weakness in our data reporting system, the data are not reflecting our efforts. These are areas I think are some of our major challenges. For us to move forward with this, I think we need to form a coalition, strengthen that coalition. It's like the patients, those affected, are being neglected. There is need to bring them on board in terms of creating advocacy, making sure that they link patient to care, making sure that they ensure that those on treatment are actually retained. So please, we need to bring these people on board. I think it's very, very important. And also another factor is the need to continue to sustain that public awareness is very, very important. Some people don't know the difference between B and C. They don't know about any other type of viral hepatitis. So these are areas I think we need to actually create that public awareness is very, very critical. Also, there is need to build critical mass of healthcare workers in the country, especially at primary and secondary facilities, very, very important. Also, we need also to advocate both locally and internationally on how we can subsidize or even provide free treatment. Because in Nigeria, we have up to about 20 million people who are currently living with viral hepatitis. Also, we need to strengthen our data reporting system so that we can use it to actually inform our decision making. Also, I would like to acknowledge the fact that some of these pilot surveys has actually provide evidence, and there is need for us, therefore, to scale up some of these findings to other areas. And finally, I think there is need for us to integrate viral hepatitis. It cannot stand alone, and we've started that with HIV, also with other programmatic areas like sexual and reproductive health care, maternal and child health, and so on. Thank you very much.
Thank you very much to our colleagues from Nigeria. It's really nice to see the close collaboration between the research, the implementers, and the local government. It's essential for policy change and, as he said, for scale up. Moving now to the next part of the panel, George Nyandaro from World Hepatitis Alliance in Zimbabwe and Professor Kowo Maturin from Cameroon. First question is to Mr. Nyandaro. You are an epidemiologist working on HIV, hepatitis, TB, and STIs, but you're also an activist for the World Hepatitis Alliance in Zimbabwe. Can you please share more about your personal experience with hepatitis B and your work as an advocate? What needs to be done at community level to create more awareness and advocacy for hepatitis B interventions?
Thank you so much. As said, my name is George Nyandoro. I lost my mom due to viral hepatitis. I'm an epidemiologist. I was paying much attention to HIV. I had no idea about viral hepatitis. So except with exception of pregnant women who are tested for hepatitis B, to prevent mother-to-child transmission. This is one opportunity also we need also to strengthen in terms of child transmission, to make sure pregnant mothers are all tested, they've got access to hepatitis B testing services. Thank you.
Thank you very much, George, for sharing your personal story. Professor Maturin, Cameroon has been very progressive in terms of access to DAA treatment for people with chronic hepatitis C infection. Can you please speak more about this testing and treatment program in Cameroon, and how can the findings from the STAR hepatitis C self-testing research inform scale-up of testing and treatment coverage?
Thank you very much for the opportunity and for the question. As we are talking about Cameroon, which is a country of high burden of viral hepatitis. The nationwide prevalence of hepatitis C is at around 2%, and that of hepatitis B is at around 8%. If you consider the population of the country, which is about at around 30 million people, inhabitants, that make a total of 700 and for hepatitis C patients and 2.4 million for hepatitis B. And these figures of prevalence vary gradually among low-risk and high-risk population, among age groups. Hepatitis C is more frequent in elderly. And we think that historic mass campaign and immunization during the year 60 and 70 and even early 1980 explain this high prevalence of hepatitis C among our population. For hepatitis B, this is explained by the predominantly mother-to-child transmission. So why saying this? You can understand that hepatitis C is really a major problem in our country. There is no formal program for hepatitis C against hepatitis as that against malaria, tuberculosis, and HIV. But the fight against hepatitis C, against viral hepatitis in Cameroon is within the Sub-Directorate for Fight Against HIV and transmissible infection at the level of Ministry of Public Health. This in Cameroon, as we realized in 2000 and 2020, as we realized that even WHO changed the paradigm. If you see the global health sector strategy, 2016 to 2021 WHO, it is on viral hepatitis, whereas in 2022 to 2030, they changed the paradigm and elaborate a global health sector strategy on HIV, viral hepatitis, and STI. So this makes us more comfortable in a way that while taking those infections together, we can join resources to be more efficient. While saying this, the directorate has created several centers to treat viral hepatitis in Cameroon, starting in Yaoundé and Douala, which are the main cities of the country. And later, they have decentralized by creating other centers that supervise the already existing centers. The mission of those centers is to organize sensitization. As one of the previous speakers said, the awareness at the level of the people is very low, and low for a silent disease. And if you take the example of George, many people in our country still are diagnosed at the level of complications. where you can't do nothing. When they have already developed cirrhosis or liver cancer in a setting where you cannot do chemoembolization, you can't do liver transplant, even if you treat viral hepatitis, the complication is still going on and the people will die from that complications. One of the mission is therefore to sensitize. And this sensitization is done either routinely or during campaigns. And what we organize is, we used to organize campaigns during the World Hepatitis Day. And the innovation in Cameroon is that instead of organizing activities in one day, we organize activity in the whole month, from July till the end of August. That helped us sensitize and screen more patients. And those who are not screened during those period have to go and do their screen from their pocket, because during the campaign, the tests are offered either by the Ministry of Public Health or by our partners. The second mission is to treat those who are positive. As you have rightly said, Cameroon has been progressive in providing direct antiviral agents. Direct antiviral agents is available in Cameroon since 2016. And from that period, we have been able to treat more patients. We have been able to treat more patients with good results, because the study that we have done have shown